Hello, everyone. I want to start by thanking you all of our viewers out there, and welcome you to Medical Student Grand Rounds. I am Bryce Stringwald. I'm a fourth-year medical student and a member of the Medical Student Grand Rounds committee. Medical Student Grand Rounds is a lecture series that is given to basically inspire medical students and be able to showcase medical student achievement. This series, it occurs the first and third Tuesday of the month, starting at 12 p.m. and is conducted via Zoom. Today, we have a spectacular presentation lined up for you. Kylene Daly and Tiffany Loftus are going to be presenting to you on trauma-informed care for survivors of sexual assaults. Coming up in some of our other talks coming up in February. We're going to have two complimentary talks that are focused on social determinants of health and mental health in the underrepresented minorities. So Jessica Munoz is going to be starting us on February 2nd, followed by Chris and Newkirk on February 16th. Both are fourth-year medical students with deep passions for diversity and inclusion. So we are excited to have them share their experiences with us. We also wanted to make you aware of our YouTube channel as well, where you can view all of our past presentations. To do this, the easiest way is just to log on to YouTube, search Medical Student Grand Rounds, and be sure to subscribe to our page so that you can get updates when new lectures are being posted. During this talk, we will be utilizing the chat function this time to make the session a little bit more interactive. Throughout, feel free to put any answers you have into the chat. And at the end, there may be some time for some questions as well that you may have for Kylene and Tiffany. And now, without further ado, it is my great pleasure now to introduce Dr. Pat Ecklar for today's introduction.
Yeah, thanks, Bryce. I'd like to echo your welcome to students that are participating in today's grand rounds. I'm the Associate Director of AMRCC, which is where I connected with this topic and with Kylene and Tiffany. And I just want to recognize Ashley Fernandez, who's in clinic all day on Tuesday. And Dr. Fernandez is the director of the course and did most of the work as far as getting this topic put together, published, presented, and so he may be able to join us at the end. I'm not sure, but depending on how his day is going. But our speakers today are Kylene Daly, who's a fifth-year MSTP student. She is studying neuroimmunology as it relates to Alzheimer's disease for her dissertation. Tiffany Loftus is a fourth-year medical student applying to OBGYN. Both Kylene and Tiffany have received advocacy training during their medical school training. Since February 2018, Kylene and Tiffany have worked alongside the AMRCC team to create, implement, and evaluate permanent curricular component for AMRCC, which of course is the ambulatory sub-internship course for all Med 4s. Together, they have presented and led training workshops at institutional forums, which was the Mo Mullet conference, the annual Mo Mullet Symposium, and then also nationally at a conference at New Orleans, in New Orleans, which they presented. And there's actually a paper coming out of this that's being submitted to academic psychiatry. So they're going to talk a little bit about their journey, how this came about, some basic tips, and we will be monitoring the chat and should have some time at the end for some questions. So Kylene, I'll turn it over to you.
Great. Thank you so much, Dr. Ecklar, for your introduction and, of course, all your mentorship over the past few years. So hi, everyone. Good afternoon. I just want to thank Student Council for inviting us to give this talk and to all of you for joining us today. So today we are talking about sexual violence, which is something that impacts everyone, whether it's been a personal experience, a loved one, or just in the media. Previously, our LSI medical school curriculum addressed sexual violence as a protocol, but in our experience working with survivors, we recognized that this was not enough. A space for a deeper discussion about the consequences, the challenges, stigmas, social justice factors, emotions, ethics. All of this was needed to prepare physicians to care for sexual assault survivors. But teaching these topics and actually figuring out if students really get it is not so easy. So today we present on how we moved past the medical protocols to train medical students to empathetically respond to survivors. So today, as Dr. Ecklar alluded to, there will be multiple opportunities for discussion. So with that comes a few guidelines. First of all, we will occasionally use gendered pronouns in this talk. Females are most often victims and males are most often perpetrators, but remember that males can be victims as well, and that transgender folk are at a very heightened risk for sexual violence. We assume that everyone came here to learn today. Everyone is at a different place in their understanding, and that's totally fine. We always assume good intentions of our participants, and we hope that you give that to us as well. It's important to distinguish between being uncomfortable and being unsafe. Understand that it's okay to be uncomfortable, as survivors need us to learn how to be comfortable with the uncomfortable so that they can heal. We recognize that given how common sexual violence is, that there are likely survivors and co-survivors present today. A co-survivor is anyone that's supported a survivor, and this role can be particularly traumatic as well. We have very limited descriptions of violent encounters, but we will discuss difficult issues. Both Tiffany and I are trained advocates and can be contacted after the presentation for support. So what are we talking about? Sexual violence is any time that sex is used as a weapon. This includes rape, trafficking, harassment, stalking, and intimate partner violence. We typically refer to victims as survivors, but it's important to clarify what someone wants to be called. It's important to remember that no survivor is the same. Survivors will respond differently to their trauma and need and want different things during their recovery. The statistics are just here to remind us that likely every day we interact with a survivor, given how many people have experienced sexual violence. So a very important concept is that sexual assault is not at all about sex or sexual desire. Rape is a weapon that perpetrators rely on power dynamics to use. When perpetrators use their power over another human, it can cause victims to feel shame, embarrassment, and a loss of their own power and autonomy. In our society, we view vulnerability as a weakness with significant stigma attached. But vulnerability is a sign of humanness. Everyone at some point in their life is vulnerable. So we wanted to open it up for discussion here. What are some power dynamics that perpetrators capitalize on? You can throw your answers into the chat. So what are some things that maybe make a victim of sexual violence vulnerable to another person? Yeah, physical size is an important one. Socioeconomic status, dependence on money. Yeah, something like dependence on money or even addiction can make someone vulnerable. Or some other things. Yeah, definitely race, minorities, along those lines, culture as well. Different cultures view sexual violence differently and may have a different response to a survivor. Anything else? So those are all really good examples. Other things, gender, of course, and gender expression. The LGBTQ community is particularly vulnerable. People who are disabled. Immigration status is a good one. They might not have access to the same resources. Really, to summarize, all of these people are people who are perceived as less than by society. They're people who are not as easily believed. And it's overall easier to justify violence against people that society does not value. So we cannot and we really should not avoid these vulnerabilities, but instead we need to work towards a society where vulnerability, differences, uniqueness are actually valued. Until then, survivors who have been devalued by society will continue to feel as though they are less than. They will be embarrassed by their vulnerability, and we will continue to fail to hold perpetrators accountable. So today we're going to talk about several topics and hope to answer some questions. The first is, why is innovative bioethics curriculum on topics like sexual violence important? Next is actually, what is trauma-informed care? The next question is, how do we build an ethics curriculum on these topics? And was this curriculum a success, which we'll go over briefly? And then lastly, what are the basics to caring for survivors of sexual violence? And for this, we'll use a case discussion to go through some tips and some basic points. So I think Tiffany's having a little bit of trouble connecting. I don't see her here, so I will keep going and hope that she is able to join us soon. So we had to build a curriculum on a topic that has lots of complications for the patients as well as the physician. So sexual assault and the medical encounters that follow have so many ramifications and things to be thinking about. This includes legal aspects, which can be quite daunting for the physician, thinking about their medical records being used in a court of law. And then, of course, this is also daunting for the patient who's going to have to undergo, if they choose to, a forensic examination, which is extremely revealing. And then there's the medical issues. There are so many medical complications that can come from sexual violence, not just in the short term, like an STI, but also long term, like PTSD, depression, other things that might require psychiatric help. And then lastly is the social network that's involved. So survivors can often feel like they've lost their support network. For many survivors, it might even be a support person that assaulted them. Of course, there's the other socioeconomic status factors that we've mentioned before. And this is true for physicians too. If physicians don't have that support network after watching or treating a patient, it's going to be complicated for them as well. But the basics to remember from all of these complications, just two main takeaways to help you gather yourself in a complicated situation like this, is to remember that a physician might be the first or only person to ever tell a survivor, "I'm sorry that this happened to you, and I believe you." This establishes trust that encourages survivors to continue to connect with resources and continue to receive medical care now and in the future. And importantly, this gives you time to ground yourself and remember what you need to do for this patient. So why do we need an innovative ethics education in medical curriculum? I mentioned vulnerability before, but we wanted to truly emphasize the point because traditionally in our society, vulnerability is viewed as a weakness. Everyone wants to avoid being seen as vulnerable because it's weak and there's a significant stigma attached. But everyone experiences vulnerability. It could be a woman walking alone at night, like this woman who's told that she allowed this to happen to herself, or a man who has an emotional response to his rapist being told to man up. But it's moments like this when we can recognize and respond with care to the vulnerability of another human, that we recognize the dignity and their value, and we become more human ourselves. This is what gives us the ability to respond empathetically to all of our patients, including sexual assault survivors. So why do we need an innovative ethics education in medical education? Well, first, we had lots of barriers to overcome to implement something. First is that I know you all are in the midst of LSI or are familiar with it, and there is a lot going on. There's not a lot of time to add something else. Second, the relevance. So is sexual assault on board exams typically? There's definitely a perceived lack of expertise on this topic. Who do you go to? Who is the expert on such a complicated topic? It's often perceived as fluffy or extra, or does this really matter for my patients? Is this going to affect their outcomes? There's also a lack of outcomes data on the actual education. So can we teach ethics? Realizing if it's effective to actually teach it in the classroom, or can students just learn it on the fly and we hope for the best? And then lastly, just wondering if ethics is really teachable, and if this is just too subjective and people come with their own understanding and we can't really change it. So what are the benefits to making a bioethics curriculum focused on sexual assault? Like I said before, the old OSU COM sexual assault curriculum just provided a protocol for caring for sexual assault survivors. And of course, this was extremely important. It gives basic resources. Who does a rape kit? What's in a rape kit? what medical testing or psychiatric evaluation is relevant, but all of this could be easily looked up online when necessary. So the benefits of having a sexual assault education would be to strengthen a healthcare provider's ability to respond empathetically and give them the confidence they need to be able to do this. To actually understand how social injustice plays a role in different medical issues, including sexual assault. So like we talked about before, different vulnerabilities include things like race, culture, and all of these things physicians need to be aware of will impact their patients. And then the last thing is just understanding that there are multiple members of the healthcare team that play a role in recovery, and physicians do play an important role and need to be prepared, but they also should rely on their counterparts to be able to provide the most effective care for patients. So when we started our curriculum, we surveyed students at the beginning and we asked if students felt like they were prepared to care for survivors of sexual violence. And these were, of course, Med-4 students who were at the start of our curriculum. And we asked them if they felt LSI had prepared them. And we saw an even distribution between agree, disagree, or neutral options, meaning that there was a gap in between how some students felt if they were confident or not to care for these survivors. So of course, we wanted to address this gap. So let's summarize what we've talked about so far and introduce where we wanted to go with our curriculum. In the United States, 1 in 3 women and 1 in 6 men will experience sexual violence sometime in their lifetime. Sexual violence, of course, being that umbrella term, which includes rape, intimate partner violence, and any other time that sex is purposefully used as a weapon. Ultimately, survivors experience a loss of their power and autonomy during an assault. Survivors can require immediate and long-term care after their assault. Evidence collection is done in the emergency department, and many women report long-term psychiatric and physical ailments as a result of their assault. However, it isn't always easy for a survivor to seek out the care that they need. In our experience as trained advocates for survivors of sexual violence, we have seen and heard of many times that survivors have a difficult interaction with their provider, which causes increased fear, increased loss of autonomy and power, and no healing and recovery. The following is a quote from a survivor who shared her story with medical students as part of our curriculum. "I did not feel like I could tell my physician about my assault because she demanded to know why I was having sex at my age. Then she performed an STI test by a pelvic exam 3 days after my assault. I squirmed and she told me to stop. Now my heart rate skyrockets every OBGYN appointment." What our TBL aims to do is avoid situations like this. We want to promote environments that are supportive and empowering for trauma survivors by discussing trauma-informed care with our medical students. Our TBL provides space to talk about how sexual violence applies to different patients, our colleagues, our career, and gives students time to practice responses that are trauma-informed and unpack their feelings on the topic. So what are some basic tips for advocating for survivors? Remember that survivors of sexual assault often feel a loss of power and control. So the key is that that physicians can strive to restore that power. So to do that, you can create a comfortable setting by sitting eye level with the patient, making sure to mimic their body language and to always be considerate of their current emotional state, to listen to them. Of course, that's if they're ready to talk about it, that you will listen to them, and of course not pressure them to tell you anything that maybe they're not ready to talk about. Really important is giving survivors choices. Even if it seems like something really simple that you're pretty sure they'll take one option, it's always good to present it as a choice and let them choose. Of course, advocating for their physical and mental health as best as possible and giving them those options. And then importantly, to not expect a specific emotional response or ask them to give that. So if the survivor is sad and crying and hunched over, you may feel like, okay, this person was definitely assaulted. But just because someone may be cracking jokes with you or laughing or smiling doesn't mean that they weren't sexually assaulted. It just means that they're processing their trauma differently. And of course, not demanding any specific behavior or follow a different set of follow-up than what they would choose. So always respecting what they're ready to do next. And of course, These tips are not just for healthcare providers. I'm sure you can imagine how you could use any of these in your everyday life if you were ever approached by a friend or a family member who had been assaulted. So what is trauma-informed care that we're trying to provide for these patients? So trauma-informed care is a treatment environment that's intended to be supportive, integrated, and empowering for trauma survivors. It's a framework shift that involves switching from thinking what is wrong with you to considering what happened to you. So when we talk about these tips that I had for advocating for survivors and giving them their power back, what other kinds of populations might benefit from this kind of care besides just sexual assault survivors? And again, you can throw your answers into the chat. So who else would benefit from a provider really taking the time to make a comfortable setting, to give them choices, to listen to their concerns, to not pressure them, to tell them things they're not ready to say? Individuals from the LGBTQ community, yes, this is definitely the case for that community. All too often, physicians will overstep and ask questions that are inappropriate. PTSD patients, the same thing goes for them, especially for a provider that's not trained to appropriately address that. Other things. Any survivor of trauma, yeah, any topic that falls under this, domestic violence, ICU care is a big one in the past year. Also just like a car accident as well would be something where you really want to take the time to ground that patient and calm down with them. Child abuse, again, anything that falls under the violence. Yeah, people of color, indigenous people, populations that are typically, again, seen as less than, but need their provider to take a moment to connect with them and to listen to what their struggles are, especially for providers that really don't have that life experience. So some other things that I have here are veterans, any form of mental health issues, the elderly population who definitely need us to take our time, opiate users and people that are addicted to drugs. And then a really important one, people that benefit from trauma-informed care is healthcare providers. So healthcare providers that work in an environment that employs trauma-informed care typically feel more fulfillment at work and also are better able to cope with the stressors of the day. So how do we go from the protocols that say, chart this, examine this, do this, to ensure that students are prepared emotionally, mentally, to care for the unique individual needs of survivors? So let's talk about the fundamentals that we followed to create a team-based learning activity promoting discussion and reflection on this topic. So what were the fundamentals for our success? We utilized 5 basic steps. The first thing that was necessary was creating space. So we talked about this curricular squeeze before, where there's just not a lot of space in medical curriculum. And so what we did was we worked with Dr. Fernandez and Dr. Ecklar, who provided space within their existent TBL on family violence, which was a very seamless place to incorporate the sexual assault curriculum, and it avoided any scheduling problems with creating an entirely new TBL. The next thing we did was enlist appropriate resources to help us create this curriculum. Our primary partners were a local rape crisis center and the forensic nurses at our university and in Central Ohio. We also had several faculty expert mentors. The next fundamental was to let students lead. It's important to mention that this curriculum didn't appear out of thin air. We didn't see any examples of a discussion-based sexual assault curriculum in the medical literature. So I started by getting medical faculty, forensic exam rape nurses, psychologists to give individual lectures on the topic as part of a 10-hour mini-series. Participating students were allowed to put this on their CV by SARCO. I held this in October of 2017. Of course, the benefits of this were that there were high student participation and excitement. It generated a lot of faculty interest. It established relationships with expert partners that didn't previously have a relationship with the university or the medical school. And it made a tangible foundational curriculum with which we were able to start with. Of course, the disadvantages was that the complete burden was on a student, and this was less likely to be sustainable. Of course, it wasn't mandatory, so not all students were going to get this curriculum, and it was very time intensive and really needed to be condensed to be effective for learners. So students could lead, but we needed expertise in education and curriculum development. So our mentors, Dr. Fernandez and Dr. Ecklar, helped us develop learning objectives, which gave us a framework. We didn't have any experience creating curriculum, and this helped us give us a first step. So as trained advocates and members of the student community, we were able to effectively integrate the ideas and stories from multiple resources, including the literature, the local rape crisis center, forensic exam nurses, and the stories of survivors. We created a pre-TVL assignment, which was for individual study, which discussed topics like rape culture, the interprofessional team, required to care for survivors, the neurobiology of trauma, and different resources. We also provided 2 real patient cases and asked students what they would do and say to care for the patient. We also made test questions and application exercises, which expanded on the cases and gave the students time to reflect on their own feelings and self-care that they may need in the future and now. So the next fundamental was to utilize evidence-based methods. We searched the literature and found limited examples of sexual assault education. So instead, we were able to rely on an effective education model to create our curriculum. The team-based learning activity was a great place to allow students to discuss and learn from each other. For those of you who are not familiar with the TBL, which I think most of you probably are, the team-based learning activity occurs in phases. The first phase is a pre-class preparation, which is individual study, to which we added the reflection on patient cases. Phase 2 is a testing phase where students take a test individually, then as a group, and then are allowed to argue or appeal their answers with the faculty, or in this case, the student instructors. And then the last phase is the application phase, which are small group assignments, which of course we were building on our individual reflection. So we also planned ahead for improvement. We worked with our Office of Curriculum and Scholarship to create an IRB and measure the success of our TBL. And we found overall that a majority of students who came to the TBL and did not think sexual assault curriculum was important to their education left feeling that sexual assault was vital, or sexual assault education was vital. We also received qualitative feedback, like the following quotes. This was good information that had not been addressed elsewhere in the curriculum, helpful to have case examples and discussion, and I feel better prepared with a sexual assault case in the future, whether it be in the ED or an ambulatory setting. Thank you for doing this, it's very important. So we've been able to use feedback like this and others to guide new directions in this curriculum as we go into our 4th year of teaching it. So the last fundamental that we followed was to make our curriculum relevant and enduring. Previously, our medical school only addressed sexual assault by presenting the protocol, telling us step by step what to do. But this is often this often won't work for survivors, and in fact, can be more traumatizing for someone experiencing trauma. So our TBL made space for discussion of other factors that affect the care of these patients. Everyone comes with a different understanding and experiences. It's important to have time to unpack these experiences and reflect on how your feelings may impact your ability to provide care to a patient. The next is a society's understanding of these topics. We all arrive with different biases and understanding from the media or what we hear from friends. And again, this is important to recognize where these biases come from and how they might impact our patients. The third thing is a physician's willingness to actually address the subject. We're all asked, regardless of specialty, to screen for safety at home, and we have to be prepared to respond to a positive screen. So as soon as a patient discloses, which can occur in any trusting patient-physician relationship, we have to be ready with resources and mentally and emotionally prepared to support that patient. And the last thing we wanted to make sure we gave students time to unpack was that any patient characteristic will impact their patient's ability to recover, to process their trauma. It may mean that they interpret their trauma differently. And this includes, again, things like race, ethnicity, their culture, gender, their sexual orientation, their general health. Really anything can impact a patient's ability to, or patient's willingness to recover, to accept their assault, it can be complicated by these factors. So overall, we wanted to give students a chance to think about these topics and build skills that would last them throughout their career. So what were the advantages to building this curriculum this way and using a TBL? So a TBL is capable of covering multiple different subject areas. Ours was family violence and sexual assault. The second thing was we were able to test it in the IRAT and GRAT phase by making board style questions, which about 50% of students got one question right. So we were able to make it a difficult question. One educator can facilitate a large room. As a student, both Tiffany and I were able to facilitate a classroom. It's clinically relevant and challenging because we used cases that were real. We were able to evaluate our success, and I'll go over a little bit of the data that we got in a moment. We were able to have students show that they were able to do this by using role play. And we were able to teach ethics really by having a free exchange of ideas and allowing students to understand the experience of their fellow classmates, or perhaps the approaches that fellow classmates would use. So was our curriculum a success? So first of all, we were able to test student knowledge of the sexual assault interviewing strategies by using our IRAT in the final exam, which had the same question on it. And we saw that student knowledge significantly increased from IRAT to final exam, I believe from 40% to almost 75%. Students, and really importantly, students left the TBL feeling like sexual assault curriculum was more important than when they got there. So we convinced students through our TBL that they needed to learn this material. And this, of course, motivates students to actually learn it and to apply it. And then overall, students reported a higher level of confidence in caring for patients and friends after the TBL, though we did note that women were significantly more confident than men leaving. And of course, this is something, this is a gender gap that of course we want to address moving forward. And we also tried to analyze some other factors like URM status or transgender, but we just didn't have the numbers of students to make any significant conclusions from this. And of course, a full analysis and results are being submitted to academic psychiatry, and we're looking forward to seeing how other institutions respond to this publication. Okay, so now we'll move forward and do a little bit of a case discussion here to wrap up. And really the goal of this case discussion is to discuss together how we might foster a community that supports survivors. So I'll go ahead and read this case. So you are a pediatric resident at a social function for your program. One of your colleagues is telling a story from their adolescent medicine rotation. They said that a 16-year-old girl came in after taking a month's worth of estrogen birth control pills because she read online that it could prevent pregnancy. They continued and said, her family is basically absent from her life, and I'm almost certain this girl was raped and then panicked. Her family set her up for complete failure. You ask why the girl would take the whole package if she was on regular birth control. They respond, oh, she was on the medication for acne, so she didn't think it would work for preventing pregnancy. Like I said, no education, no support. It's no wonder that she was raped. So again, we'll use the chat. What are just some of your general thoughts on this case? Just first things that come to mind. A lack of empathy from the colleague. Yeah, you know, what was going through this person's head that they felt like this was an appropriate response. We'll get back to that in a second. Victim blaming, definitely. Just because she's not educated now, she somehow, that means that she's going to get raped. That doesn't make any sense. What are some other initial thoughts? So let's talk a little bit about the lack of, oh, here, I'll see this first. The assumption that her family set her up for failure if a patient doesn't fully understand how birth control works. Yeah, that's on the prescribing physician, exactly. So someone prescribed her birth control. Why didn't someone explain to her, you know, everything that was going to do? And really even had a discussion about sex in the first place with this patient. All of that was necessary. So those are great points. Let's talk a little bit about the lack of empathy from this colleague. So what, do you think that this colleague is just a monster, like must hate people? That's why they became a pediatrician. What really might be going on with this colleague? Any thoughts on what might cause this person to act this way? Yeah, might be uncomfortable with the situation and not know how to respond. They might not have the education and training, and they might have honestly just freaked out. Busy, burnout, yeah, this stuff can be overwhelming, especially when we continue to perceive it as fluffy in our medical education. So it would be important to address those factors as well. I don't think he's a terrible person, just doesn't have the training necessary to handle the situation. Exactly. And if you saw that and maybe thought that this person needed more training, of course, you could always ask a residency director to have a talk on it, or talk to this person one-on-one and ask them what they learned in medical school about it. There's multiple different ways to address it. And of course, it's important to remember that this person likely arrived at those different understandings of sexual violence or rape because of the way that society presents rape and whose fault it is. So has anyone ever seen something like this happen before in real life, where someone says something that you just absolutely couldn't believe about sexual violence or another topic, and been just at a loss as to what to say to this person? Yeah, definitely. I know that I have, and even with all the training that I have, sometimes it can still be hard to say something, to do something about it. But there's always small ways to interject and say, I don't know why you felt that way. Could you explain what you meant? Or even like in this situation where we asked, well, why would she do that if she thought it would work? Can give the person a chance to realize that, oops, maybe something I said was not quite right. Okay, so I'm going to change this case up a little bit. I'm going to add a few more characteristics and see how you guys feel about the case. So now the 16-year-old girl is noted by your colleague to be a Black girl. There's no more assumption that she was raped and panicked. Instead, the resident is convinced that she will be back pregnant next time, they're sure. So how does this change what's going on? Any initial thoughts on just these simple characteristics of this patient, what it changes for her, what it changes for the colleague? Yeah, an assumption about her activity level. So now that she's a young Black girl, she's got all of these different stereotypes up against her. Yeah, and a stereotype that he's expressing exactly. Another thing that's important to note here, I don't think I mentioned this before, but in this dialogue, there's no indication as to whether or not the resident is a male or a female, but all of us have used male pronouns. So it's important to remember that females can make missteps like this too. It's not just males in our society. In fact, in our TBL, we utilize 2 cases where both physicians are female. And that's a little bit of a giveaway for those of you that have yet to take the TBL. So overall, now this girl just has so many more stereotypes to overcome, so many more barriers. A physician who maybe should have taken some extra time to really understand what was going on so that they could provide adequate care. And overall, this person just missed a screening opportunity, missed an education opportunity, and really needs to reflect on what's going on. And you can definitely be a part of that by reminding them some of those good points by asking your institution to do more training to promote a program, a community, a society that effectively responds to trauma. So thanks for going through that case discussion. I'll go through a few resources here. You're very welcome to take a photo of this slide and share it or save it for yourself for the future. So these are some tips for supporting survivors both in and outside the clinic. The most important thing is to tell them that you believe them and not make any assumptions about their story. Many people don't tell because they're afraid they'll be called liars. Tell them that they're not to blame. So remember that guilt and shame are barriers to recovery, and the only thing that causes rape to happen is the rapist willing to violate another person. So they're in charge. Remember, we've talked a lot about power and autonomy today. So always screen them for sexual violence, but even if you're convinced that they were assaulted, don't pressure them to tell you. They might not be ready yet. Don't tell them what to do. And don't try to fix them. It's really not your job to fix them. It's your job to empower them to make decisions that will be helpful for their recovery. And of course, keep resources and information in your office that lets patients know that you care about sexual violence and gives you the ability to offer help and support. And of course, if you're overwhelmed, if you don't know what to do, it's always okay to say, give me a second, let me go find that for you. Remember that every time you offer support, every time you take that extra step, you could be making a huge difference. You could be reestablishing trust in the healthcare system for that patient. Or if you're a friend of a survivor, you could be showing them that they do have friends that care about them and they do have friends that care about sexual assault. And then additionally, in the clinic, you could be teaching new learners. So someone that's never seen a sexual assault case before, you may be showing them for the first time how to respond to that person. Remember that rape culture is a systemic issue, so we have to address problematic behavior and policies when we see them. That can be one-on-one, or you can seek support from trained personnel at your institution, whether that's a program director or a resource or the psychiatry department, someone that can help you address that behavior. And of course, always asking for more training from your institution is helpful as well. And then it's important to remember that you're not alone in providing care to sexual assault survivors. And you shouldn't expect yourself to be able to do it alone. So there's other physicians, there's always advocates, a local rape crisis center in most cities, nurses and the forensic examiners, counselors. So all of these people can aid in a survivor's recovery and are really can be necessary for them. And then the last thing is just to remember that all of us say things we don't mean or make a mistake. And when you do and you recognize what happened, own it and apologize for it. That can make a huge difference for a survivor to realize that someone was thinking about them after the fact. So again, just some resources. Of course, SARNCO, the Sexual Assault Response Network of Central Ohio, is the local rape crisis center that we have here in Columbus. They offer emergency room advocacy, a 24-hour helpline. They offer law enforcement advocacy. I definitely don't recommend giving legal advice to a patient. I don't even think you may be allowed to in some circumstances. And then they also have a prevention program. And then of course we have STAR, the Stress, Trauma, and Resiliency Program at OSU. This offers support to survivors and also puts on programs for faculty, staff, and students. So just to summarize the fundamentals here that we went over: creating space within a space, getting the appropriate resources together, letting students lead, but guiding them, utilizing an evidence-based method, and making it relevant and enduring. And then we have some things that we're still working on or we're in the midst of. Of course, we want to encourage other institutions to adopt a sexual assault curriculum, which we're hoping to do with the conferences we've attended, as well as the publication that we're preparing. We want to explore more of the interprofessional interactions and really see how we can prepare medical students to interact as part of a team on a complicated issue like that. We always want to create space for authentic conversations. We know we want to validate the experiences of our students and faculty because we know that there are survivors among us. And then the last thing is really building a longitudinal curriculum that introduces sexual assault at appropriate stages. Probably those of you that are younger have seen some of the modules pop up in the earlier part of the curriculum, and Tiffany and I have hand in hand in doing that as well. So I just want to thank our absolutely huge and outstanding team of mentors and helpers that have helped us get to this point. First, I just want to say thank you so much to Tiffany, who helped me put this presentation together. She is at a clinic outside of Columbus, and the internet there was just not going to work today, I guess. But her and I have really done this together, and I do not think that I could have done it alone, emotionally, mentally, intellectually, any of that. And so to her, I'm just so thankful to have her. Our faculty mentors, Dr. Ashley Fernandez and Pat Ecklar, really have just taught me what it means to be a medical educator, to feel really passionate about a subject. Amanda Smart with the Office of Curriculum and Scholarship helped us put all the data together and find that our curriculum really was working. And then just an absolute slew of faculty and physicians that have helped us learn about all the aspects for caring for sexual assault survivors. I just want to remind everyone that Tiffany and I are both trained advocates and willing to talk to students whenever they may need. And thank you, all of you, for participating in this talk. So I will open it up for questions.
I think we're going to use the chat for questions. Just a couple quick observations. This is a great example of student-initiated curriculum content reform, and this is new curriculum. There's certainly something that didn't exist when I was a student here. Dr. Fernandez graduated much more recently than me from Ohio State, and it was not covered. I think it's important to note that it is being expanded into other parts of the curriculum. And I think a point that stuck with me from working with this topic and watching some of the previous presentations, this will confront you no matter what specialty you go into. Kylene had an example at the Mo Mullet talk, an endocrinologist seeing a patient whose diabetes is out of control. Neighbors, you're a radiologist, but you have a neighbor who's dealing with this kind of problem. Dr. Fernandez talks about hearing from a colleague from medical school who was experiencing, the wife of a colleague from medical school while he was still in training. So this is not a topic that you can just sit back and go like, oh, just make sure emergency medicine docs, OB, psychiatrists, et cetera, understand it. It's something that you may be faced with no matter what you go into. And the other thing I'll just throw in is I work with LG and LP, so I watch a lot of OSCEs, and the opening question of, so what brings you in today? How was the parking? How's the weather? How about them Buckeyes? That isn't really that, that's not appropriate. I'm sorry, I believe you, help me understand. It's just a different approach to the information gathering that we're so used to doing. And so I think that's another thing that has struck me as I've worked with this topic. I think Dr. Fernandez is probably still in clinic, but you can see some of his slides that are part of this presentation about the team-based learning and the ethics side of this. And so his footprint is all over this topic. And so I think that it was a great presentation, Kylene, and I was hoping Tiffany could get on so she could answer all the questions, but it doesn't look like that's going to be the case. So I turn it back over to you for any questions that have come into the chat.
Yeah, I see here this first one. Were there any unexpected roadblocks or resistance to implementing this curricular change, or any unexpected lessons learned? So I would say it was definitely surprising taking the 10-hour extracurricular I made and condensing it into a 40-minute in-person discussion, and maybe a reading that takes students an hour and a half to 2 hours to complete. This was just very, very unexpected. I wouldn't call it resistance necessarily. I will say that there were some people that again repeated some of those feelings that this is fluffy. Students can learn this in the clinic, and I don't agree. I think that really any provider can benefit from taking the time to discuss this, and then they can go out into the clinic and maybe teach some of those older physicians what they've learned, and people can learn from each other, and we can continue to improve the way we provide medical care. Any other questions or?
And just one other comment. You're going to be dealing with attendings who have no idea what this topic is all about. And so and that's the way it is with new information. I'm not real great with insulin pumps because that was technology that was really coming into fore, when about the time I retired from private practice. So just keep in mind, this is as you talk to people and hear about this, not you're getting content here that is not being delivered to most medical students in the country. And so the attendings and residents that you work with will not be as that knowledgeable about this topic. And I think that's an important thing to keep in mind too, and makes it even more important to become knowledgeable about it.
Yeah. The next question here was, you mentioned that men came away less prepared than women to support survivors. Do you have any insight into why and ways to bridge this gap? So actually, I was rather surprised to see this. I always thought that during the actual curricular event that men in the audience were very participatory and really wanted to learn. So I was first initially struck. But then, of course, we have to remember how society views sexual violence. Typically, we see it as a women's issue, even though we know that this is not the case. All genders have a role in preventing sexual violence. We may think that perhaps women have had more friends confide in them about sexual violence and have had to respond to it more in the past. I don't know if that's exactly the case, but that's definitely a hypothesis. And then for ways to bridge the gap, like I said, we use female physicians in our case that make missteps. And then other things will just be addressing more of the myths surrounding sexual violence and gender, and just trying to give, really to tell the men in the audience that we appreciate them learning this subject and that they do have an important role in responding to it, and that their male colleagues can be assaulted as well, and they may be called upon to support that person. So several, we can do several things, but ultimately a societal change slowly over time is necessary too. Any other questions? Well, thank you all so much. Like I said before, you're welcome to email me with questions or for support, and Tiffany as well is open to that. And I'll turn it back to you, Bryce.
Awesome. Thank you so much for this presentation, and thank you for the work that you've done to really support survivors of sexual assault and sexual violence, and educating our medical students on how to be prepared for these interactions. I think it's really good work that you guys have done, and I thank you all for it. To the audience out there, thank you for attending today. We will be back on February 2nd with Jessica Munoz talking about social determinants of health from a Latina experience. And we just want to wish you a happy and safe rest of the week. All right. Thank you, everyone.
Thank you.